Yes, ma'am, we are live. You can continue, ma'am.
Let me know, huh, Jay?
Yes, ma'am, we are live. You can continue, ma'am.
Okay. So once again, good evening, everyone, and we are back with today. Though we are always second and fourth kind of a Thursdays. October is an exception. We all know there are two moons, full moons in this month, and so we are going to have a blue moon tomorrow. Once in a blue moon, it happens. So same thing is true for diabetes dilemma. So this month we had three sessions, and I hope everyone received our messages that even in this Thursday we are having a very good interactive session. So just to repeat, you can log into Diabetes Dilemma webpage by your subscription code. Once you log in on this website, you can see all the sessions and even you can see the recorded sessions, which I try to divide into the smaller videos so that you can have time and you can see that. So welcome each and everyone for today's Diabetes Dilemma, which we have a series of clinicians' dilemma. So when we treat or design a prescription or when we do the testing of the patients, there are dilemmas because there is some news which comes from the scientific research end. To fit in into our clinical practice, there is always a dilemma. Today, we all are very fortunate and lucky to have Dr. Sunil M. Jain, endocrinologist from Indore, as a faculty who will be discussing initially about some basic things about glycemic variability in his presentation, and then we will be having a full interactive session for more than half an hour. Let me introduce Dr. Sunil M. Jain. He is DM endocrinologist from PGI-MER Chandigarh, that is Postgraduate Institute of Chandigarh. We all know, very prestigious place from 1995 batch. He is consultant endocrinologist at Total Diabetes Hormone Institute, Indore. Many of us know his famous Diabetes Institute, which is actually in totality total, not just a name. And he has n number of programs to teach, to upgrade clinicians, as well as his own research. His key faculty for CM is in PGCDM, diabetes, and thyroid societies. Conducted more than 100 clinical trials. He was a part of many cardiovascular outcome trial, as you can see, liraglutide, saxagliptin, TIMI, then Canvas with canagliflozin, empagliflozin, recently Verify and Carolina, which we know. And I can personally always say that when you yourself is a part of principal investigator from one of the big centers in India, like Sunil Jain, his opinion about these trials carries some different weightage, some different significance, and his opinions will always help us. His major interest, technology solutions in the field of diabetes, thyroid, and endocrinology. He has contributed chapters in textbooks on diabetes and endocrinology. Author of the book, How to Get the Most Out of Your Pump. And I have used his slides in many of the times when I am explaining insulin pump use to my patients, as well as if I am conducting some workshops of insulin pump. So once again, thanks for that. And even our knowledge has increased and we can use in a better way the insulin pump because of Dr. Sunil Jain's interest and the way he distributes the knowledge about it. So we become a better diabetologist for taking better care. Today's program, Glycemic Variability, is in...
Sorry, ma'am.
Yes?
Can you please make the full screen?
I'm on full screen.
No, ma'am, it is not visible to anyone. Sorry to interrupt you, ma'am.
So should I stop share and again share?
Yes, ma'am, please, ma'am. Yes, ma'am, you can just click on enable editing.
So today's program is sponsored by Sanofi, and Diabetes Dilemma sincerely thanks Sanofi's contribution for today's event where we are going to discuss glycemic variability. Thank you so much. So I invite Dr. Jain, Dr. Sunil Jain for his presentation. Thank you. So Jay, was the slides visible or no?
No, ma'am, it was only the first slide. The slide was not moving, ma'am.
Yeah, Jay, can you allow me to share the slide?
Yes, sir, definitely, sir. You
Yeah,
can.
so please allow me. I will move from the slides here. It will be easy
Done,
for
sir.
me.
Done, sir, done. You can try, sir.
So good evening to everyone. And I'm thankful to Dr. Shailaja for giving me this opportunity. And this COVID era has given us a lot of learning, out of which one is these kind of virtual sessions, which have turned out to be very useful now. So one area where I'm going to discuss will be related to glycemic variability. Now, this is an important topic. What I'm going to do in next, say around 20 to 25 minutes, will finish my presentation. And then any questions are there, then I can discuss in more detail. Now, we understand that when we are treating a patient with diabetes, we want to keep their glucose levels in the normal range, for which we have definition for the normal, fasting, and postprandial. And then we want to keep the glucose most of the time in a defined range. And when we try to do so, obviously, a average glucose which we measure in the form of HbA1c will come in that defined range. That is what is the practice being done till date. But now in last around 10 years, there is a lot of change in the understanding about the management of diabetes. And there now we are understanding that just few numbers of glucose or just an A1C is a single average number doesn't give us a lot of information. We need more information if we want to improve the diabetes care in the current scenario. So this is the three areas which I am going to discuss, but my most major focus will be on the point number one, that is addressing the glycemic variability. We understand that we need to monitor glucose, otherwise we cannot treat our patient, because in diabetes, basically we are treating the chemistry. So we need a glucose value to understand what is going on wrong in the patient and where to treat and where to adjust the doses. And for that matter, for years, our patients were managed by urine glucose monitoring, then laboratory glucose, then self-monitoring glucose, and now we are entering into the era of interstitial fluid glucose monitoring, through which we can have a continuous glucose monitoring.
Sorry to interrupt. I can't see slides, Jen.
Slides are not visible?
No.
No, sir.
So have you shared the screen?
No, I have stopped sharing.
Let me check it again, because the
Slides दिसत नाही आहेत सरांच्या. जय,
let me recheck.
Yes, ma'am.
स्लाइड्स दिसत नाहीये.
हाँ मैम, वो सर को शेयर करना पड़ेगा. So I need to share this.
Can you put the slide share icon for me?
Yes, sir. It will be visible downwards only in green color, sir.
Yeah, that I know, but
Yeah. If you
yes.
just yeah, just you need to share your screen and then you can. Yeah. Now it is visible, sir.
Yeah. So these are the three areas which I was talking: addressing the glycemic variability, then the second generation basal insulin as a suitable option to address glycemic variability, and comparing the second generation basal insulin in the light of glycemic variability. But anyway, the basic funda is we have to understand the glycemic variability. Then the therapeutic options will be obviously those therapeutic options which does not cause big peaks or troughs. They will obviously reduce the glycemic variability. So in the current era, when we are treating our patients, we have to have a glucose value. And for years, we had limited information, and now we are entering in the era of unlimited information. And that unlimited information has to be presented in such a manner that we can utilize in day-to-day practice. And that is what is the newer concept which I am going to discuss. I understand that when we practice in a country like India, these technology tools will take some time to move. But looking to the rapid development in technology And if we look at the way the cost of these technology is getting reduced, I will not be surprised if a large number of our patients in next just 1 to 2 years enter into the field of monitoring glycemic variability, not just glucose fasting, PP and HbA1c. Because we understand that HbA1c is an average number which gives us some idea about the patient, but doesn't give enough information to manage the clinical scenario of a patient. Somebody with a glucose 400 in the daytime and in the nighttime dipping to 30 to 40 will have the same HbA1c like somebody who is keeping all the time 200 glucose. Now, both these two patients will require an entirely different clinical management. And here, HbA1c will not help us. Here, obviously, at present, the self-monitor plasma glucose will help us. But again, how often our patients are going to do that? So for that matter, a CGMS technology through which we can have a 24-hour continuous glucose monitoring, and then if these data are utilized for the management of the diabetes, they will be helping us a lot. And in addition to one as an average number, we understand that any system, any process which affects the relationship of glucose binding to hemoglobin is going to affect hemoglobin A1c. And that's how in our practice, in 5 to 10% patients, there are some reason, sometimes even more than that, there are some reasons when HbA1c is not a reliable test. So what is glycemic variability? Glycemic variability as a clinician, if you will think of, it's just a fluctuation in the glucose. Now our patients keep describing these things to us, कि sir मेरा तो sugar बहुत fluctuate करता है, right? But the issue is how to measure that fluctuation, and that is where was our limitation. And for that there were many metrics, many ways to measure the glycemic variability. So 24-hour glucose on each day, how it is behaving, if we can measure it, that is called glycemic variability. Now, since the measurement facility in a true sense, earlier glycemic variability was measured by just a glucose testing and then doing some standard deviation. But now in current era, we have better technology, and that's how we are getting more and more data about the glycemic variability, which are suggesting us that it's not just one day fasting PP to be normalized. It is not just an HbA1c. If we can keep the glucose in a defined normal range, then we can reduce cardiovascular morbidity, mortality, cognitive impairment, and even various microangiopathy complications also. Now, when the CGMS technology was invented, say around 17, 18 years ago, the first CGMS technology became available. Those days, only standard deviation and with software's MAGE was possible to be measured. So what is MAGE? If we understand statistics, all the data are distributed and we can measure standard deviation. If it is within around 68% range, that is around the mean, that is we call it standard deviation. While MAGE was after one standard deviation, whatever is the high glucose, those peaks were measured, that is called mean amplitude of glucose excursion. Now, ultimately, these kind of terminology, coefficient of variation, standard deviation, MAGE, then how many episodes are of low blood glucose, that is LBGI or low blood glucose index, or how many amplitudes of high blood glucose index kind of metrics were already available. But these metrics were difficult to practice, difficult to communicate to the patients also, and difficult to make them understand. And then in last 2 to 3 years, this good concept, easy concept of glycemic variability came, which we defined as time in range. That means if you are treating your patients for diabetes, obviously their glucose should be in a defined range. Now we understand that there are so many pathophysiologic defects, and as per natural history of diabetes, we see different kind of patients. And many times it is impossible to keep the glucose in a defined range all the time. So some caveats are created here, and that is what is the time in range concept now. So if we are doing a continuous glucose monitoring of a patient, and if we can keep the patient glucose in a range of 70 to 180 on CGMS for more than 17 hours, that means roughly for the 70% of the time, if our patient is in this range, good. That is what is one objective of managing diabetes. Suppose the patients are going down little low sometimes, then what should be the limit? At the most up to 1 hour in a range of 54 to 70 milligram. At the most 1 hour. So that is around 4% or less. For less than 1% time, patient can sometimes go into hypo. That duration should be always less than 54, should be very less than 15 minutes. And then if the patient is more than 180 for a good amount of time, for around 6 hours time, we can permit them to be in a range of 181 to 250. And for again a limited time, they should be in the range of more than 250. That is what is called time in range. And now CGM systems are now getting modified. They're reporting such a manner that patient can see their daily data, that how many hours I was time in range. That means when we are treating our patient, we are attempting that most of the time our patient is from 70 to 180 milligram. These are the recommendation for time in range, which are also now accepted by most of the organization, that in type 1 and type 2 diabetes, we want that for the 70% of the time, our patient should be in the time in range. While if the patients are frail patients, like elderly patient with multiple complications, lot of fluctuations, so many hypoglycemic episodes, renal impairment, etc., their time in range portion can be 50% for 70 to 180 and remaining 50% for 180 to 250. That is what is the aim. While in pregnancy and type 1 diabetes, we want again a near normoglycemia, which you can see in the bar number 3. While for gestational diabetes and pregnancy with pre-gestational diabetes, time in range criteria are not yet defined, but obviously we want for the most of the time they should remain in a defined time in range. And here you will see the difference of time in range in non-pregnant state is 70 to 180, while during pregnancy it is 63 to 140. So this is what is time in range. So people can have different kind of time in range, like you can see in this diagram, 3 different patients with different time in range, but they can have same HbA1c. Obviously, patient number 3 is having a good HbA1c, as well as most of the time in range. That means his glucose fluctuations are minimum. That means this patient is supposed to have minimum risk of micro as well as macro angiopathy. So that is the concept of time in range. Now, when we are treating our patients to manage their diabetes in a good way, then what kind of therapies can help us? So obviously, if we talk of oral anti-diabetic agents or insulin therapy, anything which creates an unexpected peak or a trough in the blood glucose can't keep the patient in the time in range for the defined period which I discussed. Now, when it comes to insulin therapy, we know that there is a lot of development about the newer insulin in last 1 decade. Out of that, one big development is a better basal insulin. And in presence of better basal insulin, the glycemic variability, the peaks and troughs, particularly the troughs, the dips, and many times because of a dip, there is a compensatory hyperglycemia, these things can get reduced. So we know that insulin therapy has to be initiated timely, that is fine, but with what kind of insulin therapy? And here in a basal insulin therapy, we had a lot of newer development which have made the insulin therapy more precise, more flat, more near natural, and that's how closer to the pancreatic basal insulin secretion system, And that's how we can now manage our patient for a long duration time in range. We can see here, if you see NPH insulin versus glargine insulin versus degludec insulin in these graphs, we can see that how our older generation NPH used to peak. And that's how this phenomenon like Somogi phenomenon, nocturnal hypoglycemia, night 3 a.m. hypoglycemia were very prevalent in those days. Now, with the advent of the better basal insulin, these peaks have disappeared. So we can keep increasing the dose of the patient to keep them in the time in range without fear of hypoglycemia. That is what is happening with these newer insulin. So there are many studies for that. This is the glargine U300. We know that when glargine 100 is converted to glargine U300, it becomes longer acting, because its absorption from the subcutaneous tissue is further delayed. And that's how its half-life increases and it becomes longer acting. These are the studies where they compared with the glargine U100 and glargine U300. In morning injection, evening injection, both kind of these fluctuations were tried. And you can see the green line versus the blue line. Green line belongs to glargine U300. That means more flat. If this insulin delivery is more flat, then obviously the glycemic variability will be less. Patient won't go into time below range. As I have defined, time below range is less than 70, and that we want to minimize. So patient won't go into time below range, and that's how the second generation basal insulin has improved. That is what this study has shown. And in this clock view, we can see that earlier we used to tell about basal insulin to our patient that inject at the same time. But now, with the second generation, a longer half-life, it can be a 3-hour flexibility. They can change their time 3 hours here and there. That is another advantage. And we can see here that when patients are taking glargine U100 versus glargine U300, there are less risk of nocturnal hypoglycemia. So we can we can titrate the insulin safely while keeping the patient into time in range. And for that method, for that objective, earlier we had NPH as a basal insulin, then came Levemir and then glargine U100. These are now known as first generation basal insulin, and now we have second generation basal insulin like degludec and glargine U300 or Tausio. And these are the data we are showing that the time in range is good for glargine U300 as well as degludec. And there are different kind of like here, this is the continuous glucose monitoring data, again, which are showing that there is a less hypoglycemias which are happening with these newer basal insulin. So these newer basal insulin have also shown these advantages. These are the another study where they are trying to compare the basal plus concept along with the rhizodec concept. This is a study for a type 1 diabetic population, where with a changeover, we can see that glargine U300, IDEC 100, in terms of the glycemic variability, there may be differences between these two insulin. But in gross way, if we see both insulin are doing a good job in terms of less glycemic variability. So time in range wise, there are differences. But these differences, if we will think from a practical perspective wise, these second generation insulin are quite good. For a titration, we can bring the patient's fasting glucose closer to normal with less risk of nocturnal hypoglycemia. So it's important that we should understand the importance of glycemic variability. And we used to talk a lot about the glycemic variability since few years ago also, but the problem was the tools to measure the glycemic variability were not that easily available. But now in last 1 year, the big developments have happened from the 3 companies. One is Abbott with a freestyle, then second is Dexcom, and third is Medtronic Guardian. Right? One more is the Eversense, where a sensor is implanted and there it remains for more than 90 days. And there are sensors now which can work for up to 6 months. So we started this era from a 3 days monitoring to 7 days to 10 days to 14 days, and now going for a OPD based insertion of sensors in future. Now these 10 days and 14 days sensor are now becoming available in India at present only for professional use. But now all these sensors for a patient use will become available very soon, maybe from next month onwards. Then what will happen? Our patients can buy these sensors like glucometer and strips. They themselves can put the sensors all the time on their arm, and now they can see what time in range they are. So obviously, we physician will need to change our practices just from talking glucose, fasting, postprandial, and HbA1c to the concept of time in range. And there, now it will really be a challenging that when you are seeing so much data, with that now you have to manage your patient. And in the light of that issue, these newer therapy will be a great help for us, like newer second generation basal insulin, newer prandial insulin, because with the help of these insulin, we have now the tools also available to handle this glycemic variability. So time in range, not yet very frequently measured in India. I know in US, most of the type 1 diabetes patients are measuring their time in range since more than 3 years. A large number of patients are doing that. And this is going to soon change in India also because the cost of technology is not very high now. So that's how, and these second generation basal insulin, Glargine U300, kind of second generation basal insulin has provided us a good opportunity to manage our patient in a way that there are minimum glucose fluctuation, easy titration, and if a patient now puts a CGMS and comes to us with a time in range data, looking to that with the help of these kind of insulin preparations, definitely our challenges will be minimized and we will be able to offer a better treatment to our patients. So uh, from my side, about this was about the glycemic variability, and I, as far as I understand, that this glycemic variability concept is going to revolutionize the management of the diabetes, both type 2, type 1, and in future pregnancy diabetes also. So thank you, Dr. Shaileja, and thank you everyone for listening me. Thanks.
Yes, thank you, Dr. Sunil. I will also like to show one or two slides. So once you stop sharing, I can share my screen. Have you stopped sharing?
Yeah.
So as I was saying, thanks for today's session. Thank you, Sanofi, for sponsoring this event, as well as I would like to sponsor all our sponsors of Diabetes Dilemma. So before we start discussing about glycemic variability, if we discuss more about type 2, but yes, I do have some questions about type 1 diabetes as well. But mainly we will be discussing about type 2. And in type 2 diabetes, glycemic variability is more associated with severe hypoglycemia, and more the variability, more the severe hypoglycemia, and more the variability, more is mortality, as it is seen in some papers. So I just like to share one such study, just two slides. This was just recently published in May 2020, where about more than 1,000 patients were retrospectively, which were admitted in ICU. They were studied about their glycemic variability. And what was seen, the patients were divided into four groups: low glycemic variability and high, and diabetes and non-diabetes, no diabetes. And as you can see from this screen, patients with high glycemic variability and no diabetes, in fact, actually showed high ICU as well as
Dr.
hospital.
Shaileja, your slides are not coming.
Oh, I don't know.
Yeah, anyway.
Let me see.
I think you will have to click 2 times to the slideshow button.
No, I mean, you can just click on enable editing. Then only it will be movable.
Where is enable? Oh, this one.
Yeah.
Yeah, that is also one. And then slideshow.
Can you see the slides now?
I think you should click the slideshow button also. Yeah, now it is visible.
Is it changing?
Now
Yes.
perfect. Now perfect.
Okay, perfect. So again, I think I will just show these two slides as I was trying to show you the results from this recent publication from 2020, where about more than 1,000 ICU patients were retrospectively evaluated for their glycemic variability and mortality. One can see here that patients with high glycemic variability compared to low glycemic variability, they had a higher mortality. Hospital, which is a black bar, and the white bars are hospital mortality and black ones are ICU. High glycemic variability with no diabetes, non-diabetics, this group in fact actually showed the highest mortality in hospital as well as ICU. Then next to that, lower than that was high glycemic variability and diabetes. Low glycemic variability in diabetic people showed least mortality. So glycemic variability is important for the outcomes not only in diabetes as well as in non-diabetes. We all have seen that random glucose on admission decides mortality independent of patient is having diabetes or not. That kind of studies we have seen, but this was the first kind of a detailed study, as well as the Apache score. That was also, it depends on high GV was with no diabetes, it was more. And then they tried to study some independent factors as higher creatinine, mechanical ventilation. These were the important independent risk factor and female gender. So we know that these things are glycemic variability is associated with a high kind of a mortality, which may be through hypoglycemia, or when we say that it's severe hypoglycemia in type 2 diabetes, pushes our patients for increased mortality, especially type 2 diabetes with high cardiovascular risk. Does this happen through high glycemic variability, Dr. Sunil? What is your comments or opinion about it?
So if we go back about this mortality in hospital and glycemic variability, there was around 6-7 year earlier publication was sugar control in the ICU, and that time it was the initial data came that the overall glucose didn't affected much. And then when they went into the depth, then they realized that those patients, even in those older studies, where by standard deviation calculation, higher was the glycemic variability, higher was the mortality. So glycemic variability is a important factor in IPD care, OPD care, microangiopathy, as well as macroangiopathy.
Yes. So it is somewhere. So my next question is, which is very interesting to the present scenario, that as we know that there were very good review article which says that influenza virus and the glycemic variability, the poor outcome in patients with diabetes and high glycemic variability with influenza was studied a lot, and a lot of papers were published in 2019 which were actually reviewed. So there was a very nice paper published by a scientist which I will like to share with my viewers, that actually it was animal studies in vitro and in vivo. What they studied, pulmonary epithelial endothelial barrier in animal studies. And in infected mice model, what it shows that increased glycemic variability was associated with more cell death. And also in vivo experiment studies actually are showing that mice with high glycemic variability showed severe disease, severe viral disease compared to patients, compared to the animal models which have a stable hyperglycemia. So these animal models are trying to study the influenza virus outcomes, which in patients with in animal models with hyperglycemia and glycemic variability. So even in COVID era, we all know the guidelines are suggesting that all the ICU patients need to be on continuous glucose monitoring if possible. At least should be on syringe insulin infusion pumps to have to control this variability which comes with the subcutaneous multiple injections to avoid that, so that we improve the mortality or improve the outcome of these serious patients. So not only in COVID, but in general in patients which are admitted in ICU. And when we take out this syringe pump, so my question to Dr. Jain is how we can use these basal insulins when the patients are in hospital to reduce, especially when we shift the patients from the infusion pumps to the subcutaneous basal bolus therapy. So do you think any role of these good basal insulins here when the patients are admitted?
So somebody who is on a IV insulin therapy, who is admitted and hospitalized, and now we want to switch this patient to subcutaneous insulin. And at this point of time, suppose we are considering a full replacement of insulin, that is prandial as well as basal. So now somebody who is on a continuous insulin infusion, we know that what is their infusion requirement. And there are two ways of reaching to a conclusion to decide what should be the basal insulin doses. One way is you can see the 24-hour insulin quantity or the 6-hour multiplied by 4 and finally calculating a 24-hour amount and then divide into two, half being given as a basal, half being given as a bolus. But what I generally practice and what I prefer in my practice is, if basal means basal, that means any insulin which was require a prandial, that won't be counted. So obviously, if somebody who was requiring something, say around 1.2 ml per hour to maintain the glucose when he is not eating any meal, this is the requirement. That means 24 multiplied by 1.2. That means this patient requirement is approximately 28 to 30 unit of a basal insulin. That is a very precise calculation. So somebody who is now 4-5 hour stable infusion rate, if you look at and multiplied it by 24, this is one way. Second is look at the 24-hour requirement. I generally look at the stable 24-hour stable infusion rate and I multiply that rate with the 24-hour. And that's how I calculate a basal insulin estimate. So somebody who is around 1.5 ml, I will start at least with 25 units. And we understand that basal insulin, when they are injected, they won't reach into the system immediately. While an IV infusion, once we discontinue in 3 to 4 minutes, insulin will disappear. So always give at least a 4-hour overlay. So we will definitely inject a basal insulin 4 to 6 hours prior, and then we'll stop the insulin infusion, and that's how I'm going to calculate it. You are muted, Dr. Shailaja.
One more typical term which is used in the studies is fasting glucose variability. And we always say that fasting glucose variability is associated with more cardiovascular risk. So will you like to comment about it? Because there are a good number of studies which show that changes in the fasting, like sometimes it's going 200, because many patients check their fasting glucose on glucometers. It is a good predictor of microvascular complications as well, like a peripheral neuropathy or maybe a retinopathy. First, do you want to have a first comment about fasting glucose variability? What is this? Can we diagnose it in our clinical practice?
So now that is what the glucose variability or glycemic variability terminology is changing. So earlier we used to talk like this fasting glucose variability, on one day fasting different, on another day fasting different, particularly in patient with insulin therapy, used to be very common with the era of the NPH insulin. Then with the next generation insulin, it was little reduced. And with the second generation insulin, this variability is further reduced. Because ultimately that variability will depend on the presence of how much glucose is coming from liver versus how much insulin we are able to provide from the subcutaneous injection. And if the subcutaneous injection insulin is having quite a big variability, it will get translated into the fasting glucose variability. But with the advent of these second generation basal insulin, we can reduce this fasting glucose variability also.
Yes, and one more type of patients come in clinical practice with unstable retinopathy, like maybe non-proliferative diabetic retinopathy with some complications. And these patients need a very gentle glucose control to control them without creating a hypoglycemia. So I think continuous glucose monitoring is very helpful in such patients. So, but it needs to be real-time monitoring so that we can actually on the daily basis, we can change their doses. So, how do you deal with these patients with retinal problems where actually the glucose variability is not good for the retinal vessels? So, what is your opinion or how to deal with that? Should we use CGM in such patients?
So it's very important that if we are treating a patient with diabetes who is having a significant diabetic retinopathy with a high glucose, these patients' glucose should not be brought down very fast. Because if we do so, then this is a known phenomenon known as hyperglycemia re-entry phenomenon, which leads to vasoconstriction in the arterioles and can make the retinopathy worse. And this is in one of the GLP-1 analog trial also this was observed. And that's how the retinopathy became one of the label over there because the glucose was dropping faster. So whenever we are handling a patient with diabetes with quite high glucose or whatever is the glucose, we should normalize these patients very slowly. So suppose somebody with a HbA1c of 11, 12, fasting 250, post-meal 400, and you have a information that this patient has a significant diabetic retinopathy. My suggestion will be we should take 15 days, 20 days, 1 month and bring him gradually down. And in these patients, obviously, if they are put on a continuous glucose monitoring, and now with these applications, the numbers are displaying on their screen. What we want, we can actually see, and according to that, we can execute our treatment policy.
So, thank you very much. There were two questions, as I mentioned that paper, that how high glucose variability is associated with high mortality even in non-diabetics. So, Dr. Suresh Acharya is asking, how will you define glycemic variability in non-diabetic patients? And why death rate was more in hospital with glycemic variability in non-diabetic patients? I can just add to this that whatever I read that high glucose excursions are more associated with more inflammation and more oxidative stress. And in the high ICU settings, these things important for an earlier cell death in whatever organ it is suffering. So, will you like to add anything, Dr. Sunil here?
So I feel that in these patients, definitely they might be having no diabetes, but when they were hospitalized, they might be having stress hyperglycemia. And that's how they were having a quite high glucose fluctuation. Now we know this thing not only from an influenza aspect in general, somebody who is having a stress hyperglycemia that indicates that something is already going wrong, which this stressful condition has now made it visible. So in a non-diabetic as well as a diabetic population, and even we know that any kind of acute hyperglycemia happening leads to many things, including wound, etc., granulocyte function, as well as delayed gastric emptying, etc. So I believe that his question, most likely these patients might be having stress hyperglycemia, and those people with a bigger fluctuation, obviously it's indicative of multiple things. Glucose may not be just causative. Glucose may be reflective of something which is wrong endogenously going on.
Yes, absolutely. That's what everyone thinks, and that's a great addition to the knowledge, sir. Also, I'd like to add that even in the older studies, which actually checked the admission glucose to the outcome in ICU, mortality, or the length of the stay of the hospital, what it was seen that newly diagnosed patients who were diagnosed diabetes first time are having a higher bad poor outcomes compared to non-diabetics, and that's what I think Dr. Jain was mentioning here, that who get diabetes first. Also, a glycemic variability suggests a kind of a autonomic neuropathy, which has an association with cardiovascular autonomic neuropathy, and this association has very well studied, and there is an independent association. So glucose variation has association with cardiac autonomic neuropathy, which again increases the sudden deaths as well as the cardiovascular poor outcomes. So now a simple question is how can we measure, is there a way to measure glycemic variability by doing home blood glucose monitoring? If we are not using CGM, is there a way to measure?
So if we don't have a CGM, then the best way is to do multiple times of self-monitoring. And there we will require at least 5 to 8 times of the glucose value. Just 1 or 2 number will not help. And suppose somebody does for 3, 4, 5 days these kind of monitoring, then nowadays applications are there which can calculate the standard deviation. And any standard deviation will come as a milligram number. And if that milligram number is 60 milligram or less, the lower is the number, it is better. That will indicate that the person's glucose from the mean, suppose we have 10 values, 110, 160, 180, 152. Now, obviously, there will be one average that is the mean, right? When we will divide all divided by the total observations, it will give us mean. Now, for each value, how much it is deviating from the mean, this is called standard deviation. And by this standard deviation, we can calculate glycemic variability by self-monitoring of glucose as well.
Okay. Yes. One more, these continuous glucose monitorings, we are using Libre Pro and from the Abbott, and also we are using Medtronic, which is real time also with the pump. Is there a difference between these two devices? I think these two are available only in India.
We have actually with the Dexcom also had marketed in India, but currently they are not doing any active role currently. So if we look at the technology wise, the Abbott technology is very easy to use and cost effective and works for 14 days. And it is factory calibration. So once patient put a CGM, they can see all the time the glucose readings. No need to do any SMPG as per because no calibration is required. On the contrary, if we use the Guardian Connect, which is the Medtronic sensor system, there at least morning and evening 2 times self-monitoring plasma glucose has to be done and entered into the system. Now, if we look at these two systems which are more prevalent and available in India, though both are FDA approved, from an accuracy point of view, and if you want to take a good therapeutic decision making, then from that perspective, this Guardian Connect sensor is considered as a better option. It has been now approved because now the Guardian Connect has the Medtronic has this generation of the sensor, and now their sensor generation 3 is available, which you are using in the sensor augmented pumps. And as you are aware that sensor earlier it was the pump alone, then the sensor connected to it, then we reached to the 640G pump, which was just predicting hypoglycemia. Then we reached to 670G pump, which is auto-adjusting the basal. And now very recently, the Europe has approved the 780G pump, which is practically fully automatic. Now all these pumps are doing insulin dose adjustment on the basis of this sensor. And here this sensor has to be calibrated twice a day because they are very accurate. On the contrary, this freestyle sensor which we are using, they are giving us a good information in general. But for a therapeutic insulin dose decision making at present, still the Guardian sensor will be better.
Yes, thank you for this insight into these new technologies and the pumps. Now, there's a question from Dr. Kadlur Satyanand. He's asking Degludec versus Detemir or Lantus. Further extension of basal therapy, any advantage for improving time in range? That is his question.
Yeah. So anybody to whom we want to keep time in range, now somebody in whom if you are giving Detemir, Lantus and patient is doing fine, that I'm not going to change anything. But if I want to control their fasting glucose and they dip into hypoglycemia in the night, I switch their insulin to the morning in an attempt that, okay, let me keep it in the morning. But to control now fasting, if I am increasing that dose, I am facing a problem in the evening. If these troubles are going, then obviously I cannot manage my patient time in range. Then I will have to switch to the insulin. And there the second generation insulin, that is Degludec or Glargine U300, will be more useful. Because if we understand this basal insulin technology, the Detemir and Glargine U100 has around 12-hour half-life. That means they will work for 24 hours. But for 24 hours, their infusion from subcutaneous tissue entry into blood is not going to remain constant. It will be faster initially and the quantum will be less later. While with the second generation basal insulin, which has a longer half-life, this insulin delivery from subcutaneous tissue to the blood will be maintained at the same rate for the 24 hours. That means you definitely can target a fasting glucose of 100, 110, 90 without the fear of nocturnal hypoglycemia. And that's how you can keep your patient for a longer time in range.
Yes, so one typical questions for the outpatients of our patients who really show variability, and we use insulin sensitizers here in our whole combinations of anti-diabetics. Sir, what is your opinion about the drug pioglitazone, which favorite of a lot of diabetologists, even I prefer a lot of this drug. So what is your opinion? Does that help to reduce this variability or improve time in range? A good sensitizer like pioglitazone.
Yeah, so pioglitazone is an insulin sensitizer. We know it is going to work on the skeletal muscle and adipocytes. Now here this is very interesting learning that we know that after meal the most of the one is the glucose. Right? And now pioglitazone being working on the skeletal muscle and adipocytes, they are going to increase the glucose disposal. So we know that pioglitazone is a good glucose lowering drug. And when you will add this drug and you will see once this drug it shows its effect, which we generally see after 8 to 12 weeks, we are going to see not only fasting, more importantly, postprandial glucose will also come down. And when postprandial glucose will come down, only then we can bring our patient in the time in range, because time in range is having a lower range as well as upper range. So I feel that the insulin sensitizers have no replacement. And we understand that with each drug there are caveats. So pioglitazone, in my opinion, is a very useful drug provided if we do a right patient selection.
Yes. So we know that we don't use glitazones much with insulins, but when I'm using a very good basal insulin, a combination of SGLT2 inhibitor, this combination also tackles glycemic variability in a better way. Do you think so?
Yeah, see, if you look at these two different drugs, SGLT2 inhibitor and pioglitazone, we know that in India, insulin along with pioglitazone is approved. In Japan, insulin with pioglitazone is not approved. In America, insulin with pioglitazone is approved. Right? Because of this bladder cancer story, pioglitazone use had suddenly gone down. But obviously, somebody who is very much overweight, there I'm not going to use pioglitazone along with insulin. Most of the time, there I will withdraw it and I may replace it with a SGLT2 inhibitor. But somebody where obesity and weight is no criteria, then an insulin sensitizer will be a good agent. Now, as far as SGLT2 inhibitors are concerned, obviously they are also a good glucose lowering agent, not that much efficient as much pioglitazone is, that we know. That pioglitazone is a far more effective glucose lowering agent than a SGLT2 inhibitor. And we know that the glucose lowering effect of SGLT2 inhibitor will depend on how high is the glucose and how high is the renal threshold alteration in a particular patient. So these are all therapeutic agents which, when added to insulin therapy, are going to reduce the glycemic variability as well as reduce the insulin demand of the patient. And particularly SGLT2 inhibitor, I believe that their addition will bring the fasting glucose on a lower side, and our basal insulin requirement may also go a little down.
Thank you. So this combination of the drugs, combination of different insulins, combination of perfect use of insulin sensitizers after individualizing and using different drugs can tackle good A1C, avoiding hypoglycemia, and also answering some problems of glycemic variability, which gives a better time in range for our patients. And that's why a good combination is the best for the patients to tackle all these issues. The just last one or two questions. Dr. Pramod Umarji from Pune, he has asked, is it a must to do daily 7-point profile in patients with diabetes and pregnancy? He has said GDM, but I am just changing it to diabetes and pregnancy. I just like to say, again, it is individualized, but I will like to hear from today's expert, Dr. Jain, what he wants to say.
Now, actually, in pregnancy and diabetes, our objective is to keep the glucose in a narrow range. As you have seen in the presentation, 63 to 140 is by the interstitial glucose monitoring. But if we'll go by the glucose monitoring, then we want that their fasting glucose should be somewhere from 60 to 95, around 70, 80 for the most of the time. And if we measure a 2-hour glucose, it should be less than 120. And if we measure 1-hour glucose, it should be less than 140. Now, obviously, these are very tight goals. Now, if we want to achieve these goals, so not 7-point, the useful thing will be a fasting glucose, because we will have to titrate the basal insulin as per that. And then we can follow any one of the two, 1 hour or 2 hour. I personally monitor 2 hour because I find it more practical to use. So if we are doing 2 hour, and if our patient is taking 3 meals a day, then 3 postprandial. If the patient is taking 4 meals a day, then 4 postprandials. So that's how these will become the 5 values a day. Now, if my patient has no problem and they are willing to do it, I tell them to continue on daily basis, because pregnancy is a dynamic state. We know that the hormones keep changing, particularly this human placental lactogen, progesterone, estrogen, etc., which generates insulin resistance. And these are the hormones which are rising gradually till 34, 35 weeks, and then they become stabilized. So whenever we are treating a pregnancy, the dose titration many times is required in many patients very frequently. And unless we monitor it very frequently, in my opinion, daily, no issues. If the patient is willing, I always tell them to measure it daily. That is the way when we can keep the patient in a normal glucose range. Because remember, in pregnancy, we do not have the glucose targets like non-pregnant diabetic patients. In pregnancy, our objective is to keep the glucose like a normal non-diabetic individual. Our objective is to keep their glucose like a non-diabetic pregnancy, and that too without hypoglycemia. This cannot happen without a good monitoring and good insulin dose adjustment.
Yes, completely agree, and that's what we do. And more the monitoring, the four PPs, PP1, PP2, PP3, we teach our patients. So within just 8 or 10 days, you can see the difference in the amount of liquor or abdominal circumference of the baby, how it is responding. So more the monitoring, it is better. And so I completely agree with Dr. Jain. Thank you very much, Dr. Sunil. So I think we are just coming to the end. I just like to say to Dr. Umarji that he has one more question, but I will like to tell him that I will take that his question in the next, when we are talking about diabetes and pregnancy. He has some questions about pre-gestation diabetes and GDM, which is very important. We will take that because it's a big discussion. I will like to take that into our pregnancy sessions of diabetes dilemma. So today, I will like to summarize. Dr. Sunil, thank you so much. Thank you, Sanofi. So we talked about glycemic variability. We had good insights about the technologies, how we can measure it in our clinical practice. We know how even self-monitoring of blood glucose can be used intelligently to know the variability. We know that variability is bad for sick patients who are admitted. At the same time, glycemic variability is bad even for our outpatients of type 2 diabetes. Fasting variability is also not good, and this is associated with increased hypoglycemia, the glycemic variability, and more mortality. So overall, our design of prescription should have all the features which will tackle this variability and will give a better time in range for our patients. The role of newer basal insulins, I will say all the basal insulin, including NPH, is very good. But as we have a better and better basal insulins, we are going to tackle this glycemic variability in a better way with the longer acting glargine as well as degludec as well as the good basal insulins. So thank you very much, Dr. Sunil Jain, and we will
Thank you.
from diabetes dilemma in future. Thanks a lot.
Thank
Yes,
you.
thank you very much.
Goodbye.
Yes, bye. So thank you very much, all the viewers, and we meet again. I think next Thursday there is something. So we are going to discuss with Dr. Yajnik about microbiome. So thank you very much, and meet again next Thursday, which is prior to Diwali. Thank you very much.